Okay, I think we're now live. So good morning, everybody. Welcome to this Health Foundation webinar. My name is Jennifer Dixon, and I'm very pleased to be your chair today for today's discussion. We're going to be discussing the interesting subject, how will the public mood shape care after the pandemic? And why is this so important to explore? Well, firstly, to be basic, public mood influences policymakers, and in particular, public mood on the NHS, which surveys show is consistently at the very top of public concerns, not just every year, but over decades. The NHS is also consistently in the media, in case you haven't noticed, especially now. So it can't easily be ignored by Whitehall or indeed by local NHS leaders. The second is that the impact of the pandemic on our lives has clearly been really profound, and that's an understatement. How the NHS has performed, the extent social care was protected, how the government managed the pandemic, how the public has coped with new forms of virtual care, all the delays to care, all of these and more are very important to track, to understand opinion, to see if there are big and permanent shifts in public opinion. And third, I mean, looking forward, there's obviously a lot of recovery that needs to happen. And there's a massive backlog of care to deal with. Today's figures show that 4.7 million people are now waiting for care, which is the highest since 2007. A third of a million people waiting over 1 year, compared to before the pandemic, which was 1,600. So that's a massive change. Will people tolerate this waiting? Will they tolerate rationing of elective care if that needs to happen? How much virtual care should we keep and develop? What forms of new technology should we try to help speed up care? And that very old chestnut, how are we going to pay for it all, especially given the fiscal overhang, or in other words, the debt that we've racked up over the last year? So there's a lot on the cards today to mull over, and I'm really pleased to say we've got a fantastic cast to help. We have Ben Page, who is very well known to all of you and long-standing chief executive of Ipsos MORI. Actually, Ben is more like a national treasure when it comes to understanding the public mood. And Ben's going to kick us off with a short presentation with some key survey findings. And then our other panelists to respond and have lead the discussion are Dr. Vin Diwakar. Now, Vin is the regional medical director for NHS London region, and he seriously has been in the thick of it during the pandemic, and many of you will have seen him being very eloquent on the podium at number 10 in the televised briefings. So welcome, Vin. Also, we are joined, very pleased to have joining us Isabel Hardman, who many of you know is the assistant editor of The Spectator and the presenter of Radio 4's Westminster Hour. Among many other things, she's a regular on the Spectator podcast, Coffee House Shots and Sunday Morning Roundup, which I absolutely recommend. And Isabel also writes excellent and award-winning books, currently researching one on the NHS. So welcome, Isabel, thank you. And also our very own Tim Gardner, who is Senior Policy Fellow here at the Foundation, working on NHS performance, amongst other things. And Tim is a first-class policy analyst, who before working with us had a long experience spell at the DH, Department of Health, working on policy and legislation, which also included a spell at the NHS Strategy and Delivery Unit. So really well qualified and an insider in his own right. So welcome to you all. So we have just over an hour, and what we're going to do, as I said, is have Ben kick off first, and then we'll have, I'll turn to the panelists who are going to give a 5 minutes response, each of them. And then we'll have a discussion, and then we can weave into the discussion some of the questions that you've asked. And thanks to those who have already submitted some really excellent questions, which we'll get to. If you want to pose a question during this session, just use the Q&A icon at the bottom of your screen. And if you see someone's question that you really like, just upvote it so it gets to the top of the file and reaches our attention, and we'll try and get to it. And finally, for the Twitterati today, today's hashtag is hashtag THF, that's the Health Foundation, THF Ipsos MORI, THF Ipsos MORI. So please get tweeting, that's wonderful. And we'll put that in the chat box. Right, so let's get started now. I'm going to hand over to Ben, who's going to tell us if the public mood really has shifted. Ben, thank you.
Let's have a look. Hopefully you can all see that. Right. you know, the NHS is, as is frequently said, one of the closest things we have to religion. And what you can see here is the monthly survey that we do. We've been doing it since the 70s, which just asks people what the biggest problem facing the country is. And you can see how the pandemic has completely overwhelmed everything in the last year. The black line, it's sort of flat. And then the NHS is typically something, you know, very often in the top 3 or 4 things that people see as a problem facing the country. You can see the economy in green there after the last recession gradually going down as a concern as things recovered. The NHS then, of course, rises. It's been in some ways lower than I would have expected during the pandemic, but that's partly because I think many of the mentions, this is a spontaneous question, are just, you know, they just start talking about the coronavirus rather than the NHS itself. Now, what we've seen in 2021 is, this is just looking at the NHS on its own. You can see now that it's starting to go back as an issue. And I think with the figures that we've seen on the waiting times today, as we get past, hopefully, the last peak of hospitalizations, it's, you know, at the moment, actually, by historic standards, anxiety about the NHS, at least spontaneously, is slightly lower than the historical average, but it is perennially something that people believe is hugely important to the country. And typically they also tend to believe it's underfunded and needs more staff. And they believe it's underfunded and needs more staff, whatever the actual level of spending. Even under the 20, you know, even in 2005, 6, 7, as money poured in, people still thought it needed more money and more resources. So bear that in mind. But at the same time, you know, here we are, March 2021. Do you think it's the best in the world, or one of the best in the world? You've got 4 out of 10 British people who strongly agree that it is, and only 3 in 10 who would strongly disagree. So you woe betide you if you say this isn't a wonderful thing. So that overall, then you've got around, you know, 3/4 of people still believing the NHS is the best in the world. We haven't got an exact comparison because this is a new random probability online panel. But if we go back to data that a time series that DH used to publish that we did for them, you can see it rising from 2007, the proportion just saying it's wonderful throughout the years of austerity and relatively smaller rises in spending. People consistently saying, 3/4 again, consistently saying it's one of the best in the world. So people, you know, we are the only country that I'm aware of where our health service features in the Olympics opening ceremony. I'm not expecting the Japanese health system to appear in the Tokyo Olympics if they have it this summer. So, you know, overall then, no sign that our pride in the NHS has been diminished. Satisfaction is a bit lower. We've got, you know, what, just under 2 in 3 people who are satisfied. But of course, again, it's not dropping off a cliff. And this is much higher than in the 1990s by historical standards. And so, you know, in some ways, all quiet on the Western Front, you could say. But I think one needs to be careful. My typical way of describing this is that the NHS is a bit like for politicians. We'll see, I'm sure Isabel will be much more articulate about this than me in a second. But it's a bit like the NHS is a sort of £600. Public opinion on the NHS is like a big gorilla, and it's when it's sleeping quietly in the corner. But once you've got it agitated and paying attention to you, you have a problem. So, you know, we can see a dip. This asks people how well or badly they're dealing with things, the hospitals and GP surgeries, the bits that the public knows best. And you can see this dip in November. Still, most people positive, but certainly noticing some of the pressures that the service was under. We've got major, you know, and of course that reflects the sort of some of the, you know, another peak of hospitalizations at the time of field work. Overall, then, will it get better or worse in the next? You know, how's it been going? You can see only a third say it's worse than a year ago, and interestingly, 30% say it's better, despite the waiting times being through the roof. Which I think again is just a reminder that although we'll see headlines about hundreds of thousands or millions of people on waiting times, it's really only when it's your mother, your aunt, you, that it really starts to cut through. And actually, if we look at May last year, before everything was, resources were poured into the virus at the expense of screening and operations and everything else. You can see expectation, the previous year was pretty much the same. I'm slightly more saying it's the same, slightly less polarized, but really so far not a huge shift, I think, to be quite honest. But that does not mean that anybody, or certainly any politician, should be complacent. And here is an example of media coverage driving things. So here's how confident are you with them to deal with people who get the virus. And you can see at the start of the pandemic, really, really optimistic, all in it together. Loads of deaths, but still really positive as it wasn't completely overwhelmed in the first wave, although we may have discharged a lot of people into care homes to achieve that. And actually care homes in passing are the part of the care service that got the biggest criticism by the public, not always fairly, during 2020. And then you can see the very deliberate strategy of putting the NHS on the 6 o'clock and 10 o'clock news every night, with people reporting just how busy it was in January. Partly, I think, talking to Simon Enright at NHS England, of course, to remind people to be careful and not catch it. And then, of course, the recovery afterwards. So confidence is now rising, generally people positive. In terms of what's going to happen over the next year, so again, despite the figures that we're releasing, that are being released today on waiting times, we've got many more people think it's going to get better rather than worse. So, let's see how plans to drive down waiting times work, or whether more resources become available, but certainly optimism about the future. And if anything, more optimistic than they were last year. And of course, people recognizing that waiting times are longer than before the pandemic. I did wonder who the 2 people in 100 who thought they were shorter were, but that's presumably a statistical error. And most people, of course, saying that, disagreeing quite strongly that they aren't acceptable. So people want to see something done. It's interesting that none of this is driving the reputation of the government in the polls at the moment. It's not, we haven't seen the government's reputation suffering. The government's miles ahead in the polls against the opposition, partly because we've got a successful vaccine program, which 9 out of 10 people say is going well. And that, to have 9 out of 10 people saying any government at any time doing anything well, is just astonishing, as many of you will realize. And so then we come finally to what the priority should be post the pandemic. And I think here, again, routine waiting times or routine operations like diagnostic tests and operations, that's the key priority. More resources, more staff, please. Do the vaccinations, do look after your staff. But interestingly, many of the inequalities that have been exposed by the pandemic, the very unequal outcomes in different parts of the world, Britain and different parts of the population. It may be because we've got middle-class phrasing here, of course, and we haven't asked a direct question, but in terms of absolute sort of immediate gut priorities, it's cutting waiting times. It's not addressing public health issues, frankly. And so if you were hoping that public health might stop being a Cinderella service, and we would have a new settlement after this, I think not. We're back to business as usual, and it will be, can you get those waiting times down, rather than the underlying causes of ill health. The end. Thank you.
Sorry, unmute. Thank you very much, Ben. That very, very prompt, very good, very clear. Can I just ask a couple of questions before we get to Isabel? Do you think that 61% thinking waiting times is unacceptable?
Yeah.
Combined with the public support for the NHS during the pandemic, can do no wrong, the vaccine rollout being best in the world, or almost best in the world, do you then see trouble ahead for the government on that? The public souring about its experience with the NHS if waiting times aren't accepted, but yet the NHS itself not being the object of blame, if you like, but a government then who's then going into a general election?
But potentially, yes. I think the point is, if it goes on for a long time and gets even worse, which potentially it might do, then it does something, as I say, will cut through. There will be, a famous person's relative will be picked up and reported on. And it's when suddenly lived experience and what people are seeing with their own eyes starts to coincide with the statistics that the government has a huge problem. So it hasn't happened yet, but I think they are nearing. The rate of increase has been very dramatic. And I think the challenge is the posh word is the economist word is the hysteresis. It's the cumulative effects of some of these delays in treatments and screenings, the number of people who are going to die of cancer because of misscreening, etc. And it's the fact that it's an oil tanker, and in a way, public opinion is not going to switch overnight from these sorts of numbers. But you could see a scenario where in 2 years, if they haven't fixed it in 2 years' time, where suddenly they completely lose confidence in the government on it, and then they have a big problem. But let's see. I was thinking at various points with the doctors' strikes during the last Parliament, when Jeremy was Health Secretary, that there would be, there might be an impact, but didn't really seem to cut through.
Yeah, and of course it's mental health as well as surgeries and things, isn't it? And just another very quick one, just while you're on stage. Wider Ipsos polling is what has been the currents on public opinion on social care?
It's just the difficult. I mean, the thing about social care is that it's complicated. Nobody knows. It's the same as we have a social care crisis and we have a housing crisis in Britain, and both of them are so complicated in terms of attributing responsibility for the average person. And I'm speaking from a house in which 2 elderly relatives died, and I only found out about continuing care when I spoke at an event like this, and somebody told me it existed. So it's so complicated, and most people therefore don't understand the means tested limit. It's one of those distress purchases that you only know about when you start to actually have to use it, and it's like death and taxes for many people. They almost don't want to think about it. So it remains an issue where governments don't get held to account. Hence, how many years it is we've been promised a solution of some kind. At the same time, the work we did for the LGA shows, of course, enormous unmet need. And so my advice to any Secretary of State is not to take responsibility for social care directly, because, oh my God, it's bad enough being in charge of every maternity unit in the country. But hey, what do I know?
That's great. Thank you, Ben. We'll come back to you in a minute.
Right. Yeah.
Let me move on to Isabel. Isabel, is there trouble ahead, and is the government now, is it alive and waking up to this potential bombshell?
Yes, thank you. And thank you, Ben, so much for that presentation. It was fascinating. And one of the things that really stood out to me was the point about the best in the world. And it's something that the Conservatives have had to, I think only really in the last probably 10, 20 years have had to accept is always going to be the case. And there's just, I was talking to a senior Tory recently who said there's just no point in talking about other funding models for the NHS. We're stuck with this one, the public love it, and if we even raise it as an issue, we just get accused of wanting to take everyone to America. And so there's no point. So I think there has been an interesting shift in Conservative opinion in recent years on the health service. And I think they've also accepted and have sort of adapted their comms strategy accordingly, that politicians never really get the credit when the NHS is doing something well. It's the NHS that gets the credit, and we've obviously seen that in the polling that Ben's just presented. Where politicians get the attention is when the NHS is going badly, and so that's why MPs and ministers should be particularly worried about the next few years, because things are going to be really tricky, and it's much harder for them to use the pandemic as an excuse in a couple of years' time, or as we're heading into the next general election, for long waiting times and for the kinds of stories involving people on trolleys and people's grandmothers not getting the treatment they needed and they would have expected pre-pandemic. So I think there is obviously an awareness of the backlog within Westminster. It's not something that's come up massively at Cabinet. It's not something that's sort of discussed. There's a coronavirus update at every Cabinet meeting, but it's very much the sort of day-to-day COVID issues rather than the longer waiting lists that's being discussed, particularly in a political context. And that's something that ministers are going to have to wise up to, because, as I say, as we approach the next election, the NHS is always an issue anyway. But if it's a badly performing NHS, then that's going to be a real problem for them. And they need to be thinking now about how they're going to deal with the waiting lists, rather than in 2 years' time when it's too late to be dealing with those waiting lists. And I know I'm talking in a very sort of hard political sense rather than in the sense of the actual waiting lists and the issues there. But that's hard politics tends to be what gets things moving. And if party campaigners, those in CCHQ, think, oh God, this is going to be a real issue for us on the doorstep, that's when things start to change. But by that point, it will be too late. So now is the time for them to be working on that. Now, one of the issues in terms of the extra spending and other things that is needed to tackle the backlog is the Treasury. And obviously this has always been the case, but I just want to explain that one of the dynamics with the Treasury that I think is quite important as we look at how it's moving quite slowly in terms of providing more funding and more certainty for NHS trusts. We obviously only recently had the settlement for the extra money for hospitals for the next few months, and that was really a very sort of an 11th hour agreement, and so the Treasury is moving very slowly on these matters. And one of the reasons for that is Steve Barclay, who is the Chief Secretary to the Treasury. He's responsible for the day-to-day spending decisions. He's the person who ministers in the Health Department and other departments will be on the phone to at 11 p.m. trying to argue for an extra pot of money that's going to be announced the next day, for instance. And his background, prior to coming into Parliament, his background is business, and he was one of the MPs who was very, very frustrated when they came to Parliament by how dysfunctional Parliament is. Now, if you're frustrated by how dysfunctional Parliament is, the NHS must look there's an interesting perspective on the NHS there, I suspect. But also he was then in the Health Department, and he again was responsible when in the Health Department for dealing with the finances. And my understanding from conversations with those who worked with him in the Health Department and those who work with him now is that experience has shaped his view of requests for money from the NHS. And we hear this a lot about the Treasury, don't we, that the Treasury through the ages has regarded the Department of Health as a bit of a basket case and basically an open plug hole into which money gets poured, and there's very little to see for it at the end. And I think that's certainly the case with Steve Barclay now, is that he's very sceptical of the ability of the NHS to come up with the requisite reforms to make the money that is being poured into it go as far as it should do. And that's one of the reasons why we have a slow response at times from the Treasury to these requests for more funding. There's also a question about how waiting lists are tackled. And again, politics comes straight into this, because the most tempting thing for ministers to do is to tackle the 12-month or longer waiters, the really long stayers on the waiting lists. And my understanding from those on the panel who are actual health experts as opposed to reporters will be able to expand on this, but that's not actually the most efficient way of dealing with the waiting list. But it is from a political point of view, because you can say we've driven down the 12-month wait. And so there's a big conflict there between what actually works and what actually sounds good as well. We're likely to get a new Secretary of State in the next few months. I think Matt Hancock is possibly unfairly taking the blame for some of the dysfunction within the Health Department in its early response to the pandemic. There is also a sense among quite a few ministers that he's not very good at dealing with Simon Stevens, who was brought in by the Conservatives because he was a good political operator. Now it turns out that he's too good a political operator, and they don't like the way he's able to out-operate them a lot of the time. And they have perhaps understandably got a little bit frustrated by the way he will just disappear when things are going badly and then pop up again at press conferences and so on when things are going better and he wants to take credit. But he is also very good at making the case for the NHS, very good at getting out onto broadcast and in select committees and dropping little bombshells that mean that ministers have to respond. And that's one of the things that has informed the the reforms that Matt Hancock and colleagues are bringing forward over the next few months are obviously only at proposal stage at the moment, but many of the changes are actually being put into practice within the health service. And I don't think Westminster has appreciated, firstly, the impact that that upheaval will have on waiting lists, on the workforce, but also just in terms of the way in which talking about the NHS for the Conservatives is a dangerous game, and having legislation about the NHS for the Conservatives is a dangerous game, and that's why they haven't had any for a decade. And obviously the last piece of legislation was particularly dangerous because of the way in which it was designed and then sold by Andrew Lansley. And they've been much more careful this time around to make sure that it's not been designed in a bunker. But they are going to have a political battle because the Labour Party is very good at turning reforms that even actually most people in the NHS are pretty happy with into a political bun fight. I think the final thing just to highlight that I don't think is being discussed enough within Westminster, and people within the NHS would say, well, it hasn't been discussed enough within Westminster for about 20 years, is workforce and the impact of the pandemic on people working within the health service long term. So we talked a little bit about the mental health implications of this, but also actually the fact that some people are not going to want to carry on full time within the NHS, or perhaps even leave the NHS entirely and go off to early retirement or something else because the pandemic has been so hard on them. And so the existing workforce crisis is not going to get better in the next few years. And I don't pick up any real discussion of that at the moment, partly because it takes so long to train a lot of these people, and short-term thinking is always the first thing that happens within Westminster. So that's me.
Very insightful. Just going back to, sorry, some hard cash questions. In a sense, you could say it's all very well for Stephen Barclay to have views about this and tighten the purse strings, but as time slips by to the general election, and if the elective waiting list is still high and not coming down for want of resources, not money, but also staffing, as you say, then that's a recipe for disaster politically, isn't it? So presumably there will have to be some unlocking of those purse strings in order to tackle this, even just to be seen to be doing that, I think.
Yeah, I guess it depends when they do that, doesn't it? Whether it's now at the time where they could actually make the difference in time for the next election, or whether it's in the run up to the next election when they just start throwing pots of money around in a panic, in a sort of, last ditch budget, a bit like Alistair Darling's budget before Labour's last general election, the nakedly political one.
Yes, and just a more technical question: how significant is the arrival of Michael Barber, who many people who are listening will remember as somebody who really was kind of Mr. Delivery, Mr. Public Service Reform, wasn't he? I visited him in his office, and he had this big sort of whiteboard with the percentages of educational achievement in different parts of the country, and it's sort of targets, deliver. Really quite sort of Blairite method, not quite targets and terror, but it was a very straightforward, as if supply of staff and investment were not an issue. At that time, actually, there was a big slug of cash, wasn't there? How is Michael? I understand that Michael Barber is going to be looking at the elective care weights. Yes.
Yeah, and there's my understanding also, and I think it was reported yesterday, that he's not just doing a review of sort of government effectiveness, but he's actually reviving the old delivery unit, which I think will be a good thing for the NHS, because you've got someone who is good at maintaining focus. And I think that's another thing that is always a risk for any party in government, that after a crisis they want to talk about other things, and political attention moves on just at the time when actually you need someone who's really sort of pulling you back to know, but we've still got this issue that we haven't solved. If the delivery unit were to be incredibly effective, surely it could also work on social care. But I mean, that's one thing that I find deeply depressing, not just the lack of reform of social care, but actually the tenor of the conversations I have with people in Westminster now. When I mention social care, they utter this sort of dark laugh, because it's just become this monumental failure of reform over again, 20 years. And they don't think anything's going to happen. Now, apparently there are reforms forthcoming. And my understanding is that the Department of Health has kept trying to sell old reforms to ministers, and they've had to keep pushing back. So there's a little bit of a battle going on. But you know, how effective can anything be without proper reform? I'm not entirely sure.
Yes, as it indeed says in the NHS long-term plan, that you know, delivery of this is dependent upon an adequate settlement for social care. So, and you kind of worry, don't you, that if all the heat and light is about the elective waiting lists in the media, that actually that might overshadow social care. So thank you to that. So let's now move to a slightly different tempo, and let's enter the NHS in London to turn to Vin for his comments about how he thinks the public mood has changed in the capital, at least over the last year or so, and what that might mean for the future. Vin, thank you.
Thanks, Jennifer. And firstly, can I thank you for your kind words in the introduction? Just to give people a bit more flavour of what I do, as well as being the regional medical director for the NHS in London, I'm also a paediatrician, a children's doctor. And actually, during the course of this pandemic, I visited, I think, probably every hospital in London where I work, volunteered as a vaccinator, and done some nursing assistant shifts to help out. So I'm talking not just as a sort of regional NHS leader, but also someone who's been at the front line as well. And I'd like to say three things. I think firstly, I'd like to take the opportunity to thank the public and describe a bit about, I think, the role that they've played throughout the course of the pandemic and the way in which they're helping us now. The second bit is how seriously we take the business of co-creating services going forward with the public and with patients. And then finally talk a bit about both our clinical ambitions and actually the ambitions of the service as a whole. So I think let's start firstly. I mean, everywhere I've been, the NHS has really benefited from the support of the public and from volunteering. We saw that throughout the pandemic. If you go into hospitals, volunteers either working in hospitals or supporting NHS staff with, you know, food and gifts and other things to lift morale, clap for carers and so on, things that had a lot of publicity. The second thing is, you know, volunteers played a key role in supporting those who were shielding and keeping them safe. And then in the vaccination program, if you go to any vaccine centre, you'll find that a lot of the tasks outside the core business of vaccinating people are being undertaken by volunteers or by voluntary organisations like St John's Ambulance. And I think it's through that that we've been able to deliver a really successful vaccine program. So, you know, 95% of those most at risk now have had at least one dose of the vaccine. That's 33 million doses given. So just incredible in my career. And as a paediatrician, I've delivered a lot of vaccine programs. I think the second thing to say is that, you know, during the course of the pandemic, particularly if you look more recently in December and in January, at one point in January, there were nearly 8,000 patients in hospital beds with COVID in London. That's nearly half of all our hospital beds. So it's inevitable that that was going to have a knock-on effect on planned care. And I emphasised that point actually when I was lucky enough to appear for the NHS in Downing Street. And that's why it's so important now, in that spirit of partnership, I think, that the public do follow the public health measures, you know, sort of hands, face, space, fresh air. And if you're called for a vaccination, go and get your vaccine. That's absolutely critical to support us so that we can do the job we want to do in terms of getting back to where we were before. So I think the second bit, if I move on then, is, I mean, we do take what the public think incredibly seriously. In London, just to give you one example, but this is happening across the country, but in London, we worked with Ben's organisation, with Ipsos MORI last year, and did a deliberative exercise with around 60 Londoners that came from every borough in London, from all age groups and all different backgrounds. And we ran, you know, they all volunteered to do it. We ran 6 workshops over the summer and really asked them what matters the most to you. And here are some of the choices we've got in the NHS in which we might approach recovery. And the first thing was, I think, the public were really clear that clinicians play a key role in deciding how to prioritise backlogs and, you know, how to treat people. And we talked to them a bit about the work that the Royal College of Surgeons has done about how you prioritise surgical waiting lists. But the second thing, and this is where you feel really proud actually about us as a country, there was a genuine heart that people felt for those experiencing the greatest inequalities. And there was a real message that the NHS should be taking broader family and social circumstances into account in how to prioritise. There was a strong message to us that the NHS has a role and has a duty actually to be in touch with everyone who's waiting on a waiting list, to tell them where they are on the waiting list, to inform them about their care, and actually to work in partnership with them about how they can support themselves and what alternative forms of treatment might be whilst they're waiting for their definitive care to be delivered. And it's really important that we do that in a way that's culturally sensitive, using different media and so on. So the final bit I want to talk about is, our ambition and the plan. So the first thing to say is that we did things very differently in the second wave compared to the first wave. And the evidence for that is that, if you just take the hospital sector, we treated 1 million more patients with conditions in January so that's in the second wave, than we did in the first wave. And the reason we did that was because we very much focused on running a number of services where in the first wave, we stopped them because we didn't know how much capacity we were going to need, and we learned from that experience and therefore kept a lot of services going. So if I give you an example, we were able to deliver nearly all of the chemotherapy and radiotherapy and cancer services that we were required to deliver. Secondly, I don't think there's a single clinician who doesn't deeply care about waiting time. So I'm in a hospital down in southwest London yesterday. Yesterday I was up in northeast London. And a surgeon has just said to me about an hour ago, his ambition is, he said, we don't want to go back to where we were before the pandemic on waiting times. We want to do better. So we don't just want to do the things we used to do better, but we want to do better things. And so redesigning the model of care, improving access, bringing assessment, diagnosis upstream in the pathway, and getting people to definitive treatment earlier is absolutely the core of what we're doing. And being able to deploy, everything that the internet age has been able to offer us in terms of technology to improve access is really critical to doing that. And the other bit I've heard is that people are prepared to go the extra mile. It is important that NHS staff are treated well and that we look after them and that they have time to recover. But I also know, and there's real ambitions for that to happen in a way that's never happened before. But on top of that, I know that there are nearly every clinician is going the extra mile. Here in the hospital I'm in today, they're operating 7 days a week. They're doing 3-session days, and they're recovering as fast as possible. It's probably worth mentioning they only closed down their last sort of escalation area for COVID patients about 2 weeks ago. So patients that are the sickest in ITU stay in hospital for a long time. And so we're only really at that turning point. So if I just finish up by talking about some of the things we're actually doing. So firstly, as I talked about last summer, and I'll talk mainly from the London perspective, but I know that this is happening around the country. We did really look hard at firstly in the interval between the two pandemics about contacting patients, knowing where they were in the waiting list and prioritising those that needed surgery in the way that the public told us that was important to us. And the second thing we did was we actually changed the way we organised some of our services. So give you one example, in London we created fast-track surgical hubs, and that's where people can go and have surgery, particularly the most common types of surgery that are they're complex for the public, but they're not complex for us. And by doing them at high volumes, we create more efficient ways of doing things. So you can get through a larger number of operations in a day than you could by mixing up and having lots of different operations being done. Secondly, they're separated from acute hospitals, so they can continue operating and they're in COVID secure environments. So we know that certainly at the height of the pandemic, the public were anxious about coming into hospital because there was so much COVID around, but we can reassure them that they're COVID secure. We standardized 29 procedures so that we're really clear what the best and the most evidence-based way of doing things are. And, you know, we've got examples across London, in Croydon and in Kingston, in Barking, Chase Farm up in Enfield. And we've been running projects with fancy names like cataract camps at Moorfields Hospital. And we're working on a project at the moment for children with dental problems called Project Tooth Fairy. So there's been lots of really intensive work done on that we're continuing to do. But last month, I think the NHS set out its plans to reduce waiting lists at national level. So firstly, we've set thresholds measured against the activity that we were doing pre-pandemic, but also taking into account the fact, you know, in our hospitals in particular, we have lost some capacity because of infection prevention control. And so you need, very simple level, you need to leave larger spaces between beds. You need time for putting on extra PPE. But there are staged increases in thresholds running through April, May, June and July. The second bit is that as part of that, just as the public told us, we're being asked to address health inequalities. So for example, we know that in cancer services, we're not just tracking the number of patients that are referred on the 2-week cancer pathway, but we're also modelling how many additional referrals we should be receiving if everyone who should come forward for cancer care does come forward for cancer care, so that we can track not just the demand that is coming through, but actually we should make sure we're seeing the right people. And in outpatient services, we've set ourselves some ambitions on the proportion of services that might be delivered by telephone or by video consultation, how we might use advice and guidance to GPs so that they can get advice and guidance from a consultant earlier rather than just referring as default, but also doing it in a way that means we actually address some of the specific issues we have for those who are digitally excluded. And we've got plans for primary care. So this isn't just about hospital care, it's about primary care and mental health. GPs need to, as we get through the vaccine campaign, also catch up on reviews of patients with long-term conditions, medication reviews and prevention in mental health services, catch up with access to psychology, community services, and so on. And the way we're doing that is by operating at a system level. Now, I'm just going to finish with my kind of final thing, because I think by operating at a larger scale, and particularly the plans to work as integrated care systems, mean that actually we can then deliver care in the hospitals that are best able to meet demand by sharing resources across much larger footprints. And so here in the hospital I'm in today, we've got surgeons from 3 different hospitals all coming in, for example, to do ENT surgery. And we've created an ENT surgical hub here, which can specialise in that. And the bottom line about that, and I'll say my final word, you know, GP in Wandsworth says that they're perfectly happy to refer patients to this hospital that's a little bit further away from Wandsworth, but not too far, because they know if they do make that referral, the patient will be seen more promptly and won't be cancelled. I think that's the key to what we're actually trying to do. Thanks, Jennifer.
I'm very grateful, Vin, for you setting that out, because a lot of people may not know precisely all the efforts that are being taken at the moment. Just given, leading on from the previous conversation we just had with the other panelists, do you think that, I think the public, don't you think that they know what's happened with the pandemic? They can forgive the NHS for having longer waiting lists because of what's happened has been utterly unprecedented. Given that patients might wear off, do you think that the NHS should be a bit more explicit about the waiting that it's now likely to have, that people are now likely to have? And I say this because I've seen some estimates which said even if the NHS upped its velocity for, say, elective care surgery by 10%, it would still take 5 years to get rid of the backlog. And if there's a message like that to give, would it not be a good time to give it now as opposed to in 2 years' time when there's been a lot more headlines? I mean, I don't know whether that's something that you feel that you can talk to, but otherwise things could get quite sticky, couldn't it? And so is now a time for, it's probably a question for the government to come clean, instead of being hoisted on this 1 year waiting time target, which still is hanging around. Should we just say, look, all bets are off, it's a different, we're in a different terrain now, this is what you can expect, and these are the priority criteria that you say the public want to have more transparency over?
Yeah, thanks, Jennifer. So I think the first thing to say is, you know, at an individual level and at a family level, if you're waiting already, I think the NHS is being open. So
Yeah.
talking to colleagues yesterday and today and across London, we're sequentially phoning patients up and saying, this is the length of the waiting list, this is where you are on the waiting list. We can get you in, see you, talk to you about alternatives while you're waiting, and this is how hard we're working in order to be able to treat you as fast and as quickly as we can. We are very focused on patients, both who are urgent and those who are waiting for the longest time. So I think at an individual level, we are being pretty honest with people about the second bit, I think, is that we fundamentally actually changed the model of care in a number of different ways, which I've described in the talk I gave.
Yeah.
So actually, I think projecting things like, how long is all this going to take? It will take longer, but actually we changed the model of care quite a lot, actually, so that we can get people to definitive care faster and work in much closer partnership with people to get that done. So actually, I think it's inevitable because there's been an impact. I think there's a huge amount of ambition and positivity about going forward about what we can do. And actually, I think, this is actually about, doing the work and modernizing the service at the same time, capturing best practice and making sure, we don't just do things the same way as we did them before and do them better, but we actually do better things. And actually, at the end of it, have a much more modern and efficient service than we had before.
Really interesting, thank you. And interesting that is coming out not just from patients wanting to embed new models of care, but also from staff as well, who are interested in doing things differently. So as you said, so thank you so much, Vin. Let's finally then turn to Tim, who I know has been on top of some other polling, which can add some flesh to the bones of what we've already discussed about the shape of care to come. So Tim, over to you. Thank you.
Thanks, Jennifer. I mean, it's been really interesting presentations, some really interesting comments so far. I've grouped up my reflections into four broad areas. So the first is that it's been really clear that COVID's brought about some big shifts in public attitudes, but the really big unknown is what's going to endure and for how long. So drawing on some of the work that the Health Foundation did with Ipsos MORI in 2020. I mean, early in the pandemic, the public experienced the government experienced quite a big surge in public support. I think that's true of various governments in other countries. It doesn't seem to be unusual at times of national crisis. In fact, it's even got a name. It's called the rally round the flag effect. So whatever we've thought of our government before the crisis, we're now all completely invested in it succeeding in a pandemic. But that support doesn't always last for very long. So what our polling showed was that there was some very strong support for the government's approach to the pandemic early in 2020, with most people thinking that the measures that were being taken were about right, but that support dropped off quite a lot quite quickly. Now, in contrast, views on how well the NHS has been managing seem to have remained pretty strong. I think the views on the general standard of NHS care, what's happening to it, what will happen to it, I think they're really interesting. I mean, we also asked this same question before the last general election, and actually people were far less optimistic then, just before the pandemic started. So in November 2019, only about 11% of people thought care had been getting better versus 25% in 6 months later in May 2020, and 30% now. So one of the questions that's occurred to me is this surge of optimism at all comparable to that rally round the flag effect that governments have? Is it a perception, a reflection of perception and experiences, or is it partly driven by our need to believe that the NHS is going to be there for us at a time of acute collective need? And if that's true, how much longer can we reasonably expect it to last? Especially if we're starting to see some light at the end of the tunnel. And as others have mentioned, despite all of the media coverage of problems in care homes, there doesn't seem to be an awful lot of sign of public outrage at the state of the social care system, which might be a stepping stone to actually putting reforms into practice. So secondly, reflecting on what the public has as their priorities for the NHS post-COVID. Waiting times have always been a really high profile issue, so it's not a big surprise that people see tackling long waits as a priority. The pressures of the pandemic caused waits to spike. The scale of the problem is enormous. The number of people affected potentially runs into the millions, which means that most of us will know, or at least know of, someone who's going to be affected by this. As Vin just pointed out, the NHS is working incredibly hard to address this backlog, and we actually saw some really major progress being made between the first and the second wave. But tackling this is likely to take some time, probably years rather than months. And as time goes on, we're likely to hear more and more accounts of people who've experienced life-changing consequences from problems with accessing care because of COVID. And that means that waiting times are likely to be a really high priority for policymakers in the run-up to the next election and probably beyond. But it's interesting to see that there are other areas. So, for example, mental health is quite high up on the priority list, and I think that continues a trend that we started to see before the pandemic. And that means that tackling waits can't be the only priority, that it can't come at the expense of everything else. The third sort of set of reflections I had was, how do the public's priorities fit with what the government has said are its priorities for the health service post-COVID? And helpfully, the government published last month its latest mandate to the NHS, which sets out what those priorities are. It includes the various manifesto commitments for more nurses, more GP appointments, new hospitals, which do match quite well what the public wants to see. But there's also a lot about, for example, building on the rapid adoption of remote appointments and the vaccine rollout. So how closely does some of these other priorities align with what the public wants? I think before the pandemic, few people had a direct experience of remote appointments, although previous polling work that we've done suggests that most people were generally open to the idea. Research by the Health Foundation earlier this year found that people who had experienced some form of technology-enabled care during the pandemic overwhelmingly reported that their experience was positive, but only a quarter said that it was actually better than traditional ways of accessing care, and 4 in 10 said that it was actually worse. So there's clearly some work to do to make digital by default an ambition that is actually backed by the majority of the public as well as the government. Isabel also touched on some of the reforms the government is setting out. The government's been understandably very keen to build those reforms as building on the success of the vaccine rollout, which has been incredibly impressive. But reforms tend to suck up a lot of time and energy. They certainly did back in 2010 under Andrew Lansley. And there is a question about how will those reforms translate into quick and obvious improvements in the main areas prioritised by the public. Finally, it's worth stressing that public perceptions aren't always correct, even though they are always really important. So the Health Foundation has recently published some absolutely fascinating work with Policy Institute. This highlights, just as Ben's presentation did earlier, that our love for the NHS remains incredibly strong, but we also tend to be overly negative about prospects for its future. And there are some quite notable misperceptions about how much we spend on the NHS, how demand is going to grow in future, and the extent to which poor health in the population is going to be a driver of that. So left unchecked, that could undermine belief in the sustainability of a comprehensive tax-funded NHS that's free at point of use. Clearly, in a democracy, it's very important that government policy is guided by the public's priorities and public perceptions. But I think we'd argue it's equally important for policymakers to improve public understanding as well. I mean, that's certainly long been a barrier to social care reform, because actually make the case for reform, you've got to highlight just how terrible and iniquitous the system is currently. And it's also important to challenge misperceptions where they arise. And that's not at all straightforward, but I think it's just as vital to good decision making, good policy making, and ultimately the future of the health and care system. And I think that's it from me.
That's lovely. Thank you very, very much, Tim. I'm just going to ask you a quick question, actually, and I suspect the other panelists might be interested to have reflections on this. Obviously, one of the things we've seen in the pandemic, haven't we, is that the pandemic has affected different parts of the country differently and different groups differently. There's quite a lot of questions we have from participants about inequalities. One way of addressing some of the backlog might be to link it to what's been called the levelling up agenda. So instead of considering that this is just a mountain of demand for the NHS to tackle and therefore needs a slug of cash, actually geographical and population differences are important to tackle as part of the Build Back Better slogan or whatever. And actually there's quite a bit of money swilling around for that at the moment, isn't there, even if it's locked up in infrastructure. So do you think that, I guess it's thinking about, do you think that the fairness angle, i.e. the levelling up angle, is one that is going to sort of become more loud over time as maybe waiting times in Newcastle may be shorter than waiting times in, I don't know, Southampton, and that would bother the public on the back of this pandemic?
I think it's, in a word, yes. I think it's easy to get quite overawed by the sheer scale of the problems and the disruption caused to elective care. We've done some new analysis which was published this week, which highlights that actually the parts of the country that have been worst affected by COVID are also those that have been worst hit by the slowdown in elective care, and are then going to have the furthest to go in order to recover to pre-pandemic levels, which were broadly, weren't meeting the 18-week standard, but were relatively consistent across the country. So I think we will probably start to hear more about that kind of thing. And I suspect it's, waiting times are a public obsession. Another is arguably the postcode lottery. So if we're hearing about the unfairness of someone waiting for a hip replacement in Newcastle versus Southampton, then that could potentially become quite an important driver of efforts to try and address this problem.
Yes, just a technical question, because it's relevant to some other questions people have. Do we collect waiting times data by ethnicity?
So, Jennifer, the first thing is, in the plan that the NHS published in the planning guidance a couple of weeks ago, we've had a very specific ambition about collecting data on ethnicity for over a year now. Yeah. But the second thing is that we will be analysing, and all parts of the NHS have been asked to analyse their waiting list cut by various different measures of inequality. Right. Secondly, to use that in planning and prioritisation. Yeah. And thirdly, to also use it not just to treat patients who are already on the waiting list, but actually to use it for case finding, because we know people experiencing the greatest inequality often have the poorest access to care, but also can sometimes normalise ill health and therefore not come forward. Yeah. And we know from the polling that we did with Ipsos last year that the public really care about inequality. And so I think we've got a real ambition actually to work throughout the service and try and systematise an approach to inequality that delivers a much fairer way of accessing the service and delivering care to people. Quickly, I'd also say, we've got some evidence now coming through the vaccine programme about the importance of very local approaches, because actually inequality is something that sits in your house, in your community, in your home, and in the place that you live. And we have found during the vaccine programme that very hyper-local approaches, as they're called, I was out doing vaccines in a bus in Thamesmead the other day, actually is the way to really work with individuals who are experiencing the greatest inequalities. It's to take the service to them and not expect them to come to us.
Thank you. And Ben, you know, given the higher up the public stakes inequalities has become, and injustices and unfairness, not just to do with the pandemic, but to do with other events, perhaps the other side of the Atlantic. Do you feel that the inequalities agenda is also going to be quite live in government for arguing for more funds to tackle quite glaring differences that you might see across the country in NHS weights, not just for elective care, but also for other things like access to mental care,
Sure.
particularly for younger people, perhaps?
Okay, I mean, there's also a good question, reflecting also on some of the comments in the chat and also on Twitter. I think so. First of all, and Vin has just demonstrated this, when you sit down and talk to people in a considered way, which is what we've done with Vin in London with the public, you get a much more balanced view than you will do in a sort of an opinion poll, which is just getting sort of top of mind reactions.
Yeah.
And I think that's one for the people who are complaining and saying my sample must be biased or something like that, or I haven't spoken to the right sort of people. The reason is that for the public as a whole, who are not sitting down every day and thinking about the detail of health policy or waiting lists or anything else, you ask them, you know, what are your top priorities, and they'll give you their top of mind answer. And the NHS has got more data and is closer to its users, I think, than virtually any other health system in the world, quite frankly. And we beat ourselves up about the lived experience, patient experience, etc. The amount of data that the NHS has about patient experience is extraordinary. I mean, it's at almost postcode level. I mean, just let me know. We can show you ratings of every GP in Britain by where the people using it live. So the data is there. I think there are sometimes questions about how it's used in a large and complex system. But I think some of the tensions around why aren't we talking more about inequality, why aren't we talking more about mental health, which of course has surged in concern over the last decade. I think there is something there where the NHS has permission to do things on inequality. The government, I think, is a bit conflicted, and we're now going. I'm not going to go into the war on woke, but there's a dynamic I mean, the bottom line is we are governed by a coalition. I don't know if I think Isabel Hardman's had to go, but we've got a coalition of social conservatives in the north and social and wealthier social conservatives in the south. If the challenge, one of the challenges in politics, to me at least, and as a pollster, I guess I can say this, is that if the government is unable to level up the northern England by 2024, which seems pretty unlikely, and people are wondering why their high street doesn't look regenerated, or why there's still a waiting list, or all the rest of it, there is a danger that they want to use some of the culture war stuff as a way of keeping their electoral alliance together. And that gets into slightly difficult territory if, in a very practical public health way, you're saying we need to divert resources towards particular ethnic groups or particular geographic areas. So there's some tensions there, but broadly there is probably more permission to do that than the headline polls would suggest. Yeah. I'll shut up.
Yes, I mean, the question is, I guess, is can the NHS sort of backlog issue be linked to the levelling up agenda in a way that might unlock some?
Well, I think you can say that. I mean, I think if the NHS said it's going to focus on the people who are at most disadvantage, I mean, the difficulty is that people like that in general, but when it turns out your granny's cataracts are now going behind a granny who is poorer's cataracts, or your hip replacement is now in Guildford, is being put behind one in Sunderland, that's where it gets really problematic. I mean, the challenge in Britain is we love fairness, and we think it's outrageous that people in parts of Glasgow live 18 years less than people in parts of Richmond. And it's outrageous that kids in bits of Hull have terrible results compared to bits of London. However, we don't actually want to pay the taxes that are necessary to drive change in those numbers. So there's a sort of dynamic tension in some of our attitudes on this stuff.
Yes, and that's the subject of a webinar or two in itself. Thank you.
Yeah.
We've got quite a few questions about the NHS will need to, if it's really going to tackle this waiting list, backlog in demand in under 5 years, it may have to do some things that are incredibly radical. To what extent, I mean, some of you have referred to this already, do you think that off the back of the pandemic, both the public and the staff delivering care are up for quite radical change? Has this pandemic sort of really whetted the appetite, and do you think that's going to stick, or people just wanting to sink back to face-to-face and sort of more, you know, traditional methods been, is what's your sense in the people that you've been, your staff and also the public from your work?
So firstly, I think from the staff's point of view, if, for example, we take remote consultations and video consultations, you know, both in the first and the second wave of the pandemic, I think the number of appointments that were delivered virtually went up to sort of 50 or 60%. And then in the interval between the two waves, it dropped back down to about 30%. Prior to the pandemic, we were delivering very few consultations by video or telephone. So I think we don't actually know yet where the right level is, and we've got to reset it. What we do know is that Tim talked a bit about the polling that we've done, and in general, people have had a positive experience. And I think that is reflected in clinical practice as well. It does vary by age. So I think in pediatrics, people have found it a pretty positive intervention, actually. And I think in my own personal practice, my fellow paediatricians would tell me actually children and young people open up a lot more through a video medium than they might do coming up to the hospital. That's much trickier, and it's probably less suitable if you've got cognitive impairment and dementia. So we've got to sort of set it appropriately. But I do think, you know, say, as I said during my talk, there is a real ambition actually to, you know, I think, as I said, a surgeon said to me today, a surgical leader, we don't want to go back to where we were. We're going to do better than that. And so I think that sense of ambition to do things radically differently and deploy technology in a way that we haven't done before is genuinely there. And we've got a real opportunity. The only other bit I'll say, Jennifer, I think that is helpful is that, I mean, the great joy of working during the pandemic has actually been that we had to sweep quite a lot of the bureaucracy away because we were in an emergency and you had to act fast, and it meant you could make decisions quickly. And what we really need to try and do is capture that a bit. I think the Health Foundation, in some of the work you did between the two waves, talked about how people like me at the centre could create central clarity, but allow local agency to allow people to design and get on with their own solutions. And I think we're quite keen to do that because we found it to be a really effective way of leading the service and moving things forward faster.
Yes, and of course, what a part of the future has also got to be, hasn't it, to try to keep people well enough so that they keep well away from the National Health Service. And I notice in all of these surveys, public health and addressing health inequalities is really quite way down, disappointingly down the schedule, isn't it? I mean, do you feel that, I mean, it's for a question for everybody, I guess. Do you think that there may be renewed interest in this? Even if it's just a sort of proximal way of addressing demand, as opposed to the deep-seated social determinants, you know, like risk factors and much more preventive care that's closer to the NHS that could, in a year or two, translate into demand. Do you see any, or is this just suffering the same fate as social care is, which is way down the pecking order? Maybe Ben.
Well, it's down the pecking order because it's complex, and you get into issues like the deserving and undeserving poor, which politicians don't really talk about, but the public still uses a frame, which is still there when you start to dig into some of this stuff. Well, those people, you know, they drink too much and they don't eat healthy food and blah, blah. But I think bottom line, ignore public opinion and do the right thing. And we need, you know, we need some massive campaigns. This is a liminal moment as we come out of the pandemic. We've busted, you know, various things have changed in Britain. One is that we're doing this thing like this we are today. The taboo against remote working has been busted in Britain, certainly in British business. And that is a fundamental change. And it means that, you know, people will lead different lives. So in terms of people taking responsibility for their health and being more aware, you know, nobody buys a car and thinks it runs for 100 years on any fuel, but people have a tendency to think their body is like that and the NHS will just fix it when the time comes. So I think there is a huge amount that can be done. And the difficulty is that it doesn't pay off next year in the way that cutting waiting times does. But, you know, ultimately, we've been talking about this now as well. I've been working with the NHS since the 90s, and many of you for much longer. We've been talking about a wellness service rather than an illness service, but why not use this as a moment and don't pay any attention to opinion polls?
Yeah, well, that's interesting coming from Ipsos. Thank you. I mean, I noticed that the role of the NHS in helping to you know, to keep people healthy enough to support growth, for example, was not at all a feature of the government's plan for growth that came out recently, or indeed its levelling up agenda. It's not really part of that. That's at least been in published documents. Tim, I wondered if you had any further comments about the public health angle.
Yeah, thanks, Jennifer. So, I mean, I think social care is probably quite a good parallel here, because, I mean, there's the question of, you know, do people, when you ask people about what should be the priorities for the NHS, then that's, you know, the people will necessarily look at that, the responses to that, as, well, what should the NHS itself be doing? And actually also, you know, that they may recognise that there are very deep-seated health inequalities, but do they then see that as being for the NHS or even the state more broadly to address, versus seeing that as matters for individuals or communities?
You're absolutely right, Tim, and they're split down. British people are split over whether it's the state or individual responsibility, and that is part of the conundrum that we're dealing with here.
Absolutely. I mean, one of the really interesting questions that we included in one of our polls last year was asking people about the different social determinants of health, how big an influence they saw those as having on the people's ability to live a long and healthy life. And then we asked about, okay, so to what extent is government or the state responsible for each of these? And you do get a really interesting picture emerge, where some things are clearly thought to be very important and very much the responsibility of the state. I think education came out top of those on both axes of the graph. But then there are other things that are just not seen as being something that the government or the state, including the NHS, needs to be dealing with. And I think that it's in those areas where we don't see those issues come through the polling quite as strongly, but actually there's still potential to do the right thing. It doesn't mean that people are disinterested.
Yeah, thank you so much, Tim. Well, we're nearly out of time. I'm sorry that Isabel had to drop out. She had an emergency childcare issue and had to address it, so she sends her apologies. But I just want to, and also we've got a kibosh coming down at 1 o'clock, which is suddenly everything shuts down. So I think we probably ought to end it there. I mean, what I've taken away from this is that I think there's trouble ahead for the politicians, quite frankly, and I think they're going to have to do something now, actually, to address this backlog that will come surely haunt them in the reaches to the general election, which may be sooner than we think. So I think that's the kind of main message, and money is going to be, an investment is going to be part of it, whether it's levelling up money or whether it's tackle the waiting list mountain backlog money. I also got very positive vibes from Vin about the extent to which there's been change and the appetite there is for embedding in more change, new forms of care, and also tackling health inequality. So I think that's a really positive thing to move forwards on. I also got the message that social care and public health, unfortunately, may be losing out in the next couple of years unless we do something more about it, because the headlines of the waiting time and NHS will take over as usual. So those, I think, are probably the main messages I've got from this this session, which has been really rich. So thank you very, very much. And also, I suppose Ben's final point: don't listen to the polls. I think was quite a lot.
Well, I mean, no politician is ever going to, whatever the only lie politicians ever tell is that the only poll that matters is the one on election day, which is why they spend millions on opinion polls. But I think I'm inspired by all this. I think there's huge, the way in which, and I think the other thing, the e-commerce boom of the last year, where we've made more progress in digitizing the economy than we had in the previous 6 years, shows that people will switch how they use things. And yes, there are some hard to reach groups for Vin and colleagues to get to, but actually there is massive unmet willingness to use new approaches, try new things. And the NHS needs to be adaptive. Exactly.
So good. I think that's a very positive note to end on. So thank you very much. If you enjoyed this, there's a recording that's going to go on the website. Tell your friends who may want to watch it. If you like this, you might like our podcast. Find that on our website or on the App Store. Next one released next week is on Levelling Up with Diane Coyle and Howard Bernstein. Very interesting that is too.
Yeah.
Otherwise, I think thank you very much for watching, and sorry we didn't get to all your questions. We got to a few of them, and excellent questions they were too. Hope to see you next time. We're going to be talking about technology and care next time, how to speed up care. That's in May. So otherwise, thank you so much to everybody. Stay well and goodbye for now. Thank you.